In now who's here and just say a huge thanks to everyone for joining us. This would be our, I'm going to look at Felix, I think fifth Meet the Team event. Does that sound right? Fourth or fifth?
Think fourth, I think.
Fourth
Yeah.
for No Pain, and this is our first following our what I think was by most accounts a successful inaugural No Pain conference held here on Western's campus. So feeling good about the momentum we've got. We certainly don't want to lose that, and we're very happy to have two more of our members of the Western Pain Research community here with us today. So we've got Dr. David Allison and Gail Teachman, who are going to be talking to us about some of the work that they do in the pain field in particular. So the way this tends to run is we have each speaker deliver about a 20-ish, we'll say, minutes sort of overview of the work that they do, followed by open conversation and discussion for about 5 or 10 minutes before then flipping over to the second presenter. So with that, I'm gonna start with David Allison. David's a scientist with the Lawson Health Research Institute and does a fair bit of work with the pain research unit there, and he's going to tell us more about some of that, what that work looks like. So David, over to you.
Great. Thanks, Dave. Okay. All right. So as Dave said, my name is David Allison. So I am a scientist with Lawson Research Institute. I'm an adjunct professor in the Department of Physical Medicine and Rehabilitation at Western. And so my talk today is going to focus around the common inflammatory etiology of depression and chronic pain, and some of the work that my lab, the Clinical Psychophysiology Laboratory, has done in this area. So just to give a little background about what our lab does, really the overall aim of the lab is to try to better understand the neuroendoimmune interactions that can be driven by chronic inflammation and contribute to both depression and chronic pain. And so we run a number of RCTs, and we're trying to explore novel intervention strategies that may be able to better treat depression and chronic pain by targeting some of these common mechanisms. So some of the projects that we have going on, we have some studies looking at vagus nerve stimulation, and specifically a form known as transcutaneous auricular vagus nerve stimulation, with the goal of targeting a key mechanism known as the inflammatory reflex to try and impact these pathways. We've also done a number of projects looking at anti-inflammatory diets, so the use of whole foods and supplements to try to treat inflammation, depression, chronic pain. We are also going to be venturing into the use of intermittent fasting. This summer and fall, we'll be getting some studies going looking at if that has potential anti-inflammatory benefit. And then we've done a number of studies both in aerobic and resistance training, and looking at some interesting mechanisms that link skeletal muscle health to mental health. And then finally, a bit of work with orthobiologics, so looking at the use of platelet-rich plasma as an anti-inflammatory and analgesic. So when it comes to depression and chronic pain, we very commonly see these present as comorbidities. And this is due in part to the fact that they share a number of common pathophysiological mechanisms. So in both depression and chronic pain, we see things like chronic inflammation, this chronic elevation in circulating pro-inflammatory cytokines. We also see disruptions in key neuroactive compounds. And one thing that's important here is that chronic inflammation and these pro-inflammatory cytokines can directly contribute to this dysregulation because of their ability to dysregulate key enzymes and transporters. And so in both depression and chronic pain, we can see things like deficits in key monoamines like serotonin and norepinephrine, elevations in pain-inducing prostaglandins like PGE2, and then also excessive production of neurotoxic metabolites. And so a particular metabolic pathway that we're interested in is the kynurenine pathway, because it's the primary route for tryptophan metabolism in the body, which is the precursor for serotonin. And when it becomes metabolized, it can result in the production of these neurotoxic kynurenines. And I'm going to touch on that a little bit more on the next slide. But ultimately, what can happen is when you have this overproduction of these neurotoxic metabolites is that it can travel to the brain and it can impact key brain regions that are important in both nociceptive and emotional processing. And so that can result in some reduction in volume, such in key areas like the hippocampus, which we do see in both depression and chronic pain conditions. And then finally, because these brain regions like the hippocampus are important in regulating key endocrine axes, like the HPA axis, It can lead to this chronic stress response, chronic elevation in glucocorticoids, and that can feed back into this state of chronic inflammation and just cause this vicious cycle. So to touch a little bit more specifically on some of the research that we do and why we're interested in inflammation and specifically its impact on these neuroactive compounds, I'm just going to, in a very basic way, outline kind of some of the effects that it has on some of these neuroactive compounds. So here I've just got a depiction of the brain. We can see serotonin and norepinephrine. Both of these monoamines are critical for serotonergic and noradrenergic signaling. And so because of that, they play an important role both in emotional regulation as well as modulating descending inhibitory pain pathways. And so because of this, they are a common target for both depression as well as chronic pain. So pharmaceutical treatments like selective serotonin reuptake inhibitors or serotonin or epinephrine reuptake inhibitors, which act to block the transporters for these monoamines. And so in doing so, slow down the removal of these monoamines from the extracellular space and help to keep their concentrations elevated. But one of the problems with these drugs is that they don't directly target the inflammation that can also contribute to deficits in these monoamines. So as I alluded to earlier, there's a number of pro-inflammatory cytokines that can directly upregulate transporters, such as the serotonin and norepinephrine transporters. And so in doing so, they actually accelerate the removal of these extracellular monoamines and contribute to their deficits, so directly counteracting the effects that our pharmaceuticals are having. But in addition to accelerating the removal of monoamines, they can also directly impact the synthesis of monoamines. And this is where the kynurenine pathway comes in. So again, the interest for this pathway is that it is the primary route of tryptophan metabolism, tryptophan being an essential amino acid and the precursor for serotonin. So you consume tryptophan through your diet, it can cross to the brain, and then it can be used to produce serotonin, or it can alternatively be broken down along this kynurenine pathway. So there's this first rate-limiting enzyme IDO. It takes tryptophan and it breaks it down into kynurenine, and then a number of other metabolites further down this pathway. But so in its simplest form, what can happen is pro-inflammatory cytokines, because they can upregulate these key enzymes, they can actually upregulate IDO. They can turn tryptophan metabolism into overdrive, causing tryptophan deficits and then corresponding reductions in serotonin synthesis. So this is a simplified breakdown, but you can see from this that pro-inflammatory cytokines can both accelerate removal as well as reduce synthesis of these key monoamines, which is why they're critical to address this when treating depression and chronic pain. On top of that, and I'm going very light on details here, but kynurenine, these metabolites, when they're overproduced, they can be further broken down along this pathway and produce these neurotoxic metabolites that can travel into the brain and impact those key brain regions as well. And then finally, peripherally, they can upregulate key enzymes like cyclooxygenase, which is going to cause overproduction of those pain-inducing prostaglandins like PGE2, and then contribute to nociceptor sensitization. So for all of these reasons, and the fact that this can spill over into neurodegeneration and endocrine dysfunction as well, this is why my lab is particularly interested in targeting inflammation. It's also an accessible target. It's something that's fairly easy to modulate. And much of the research that we've done and the research that I'm going to talk about today has focused around spinal cord injury. And one of the reasons for that is that this population does typically show a state of chronic inflammation, and they also have high rates of depression and high rates of chronic pain, such as neuropathic pain. So I'm going to talk a bit about the work that we've done where we've implemented anti-inflammatory diet to try and target inflammation in some of these pathways in this population. And we specifically chose diet, one, because it does have the ability to significantly impact inflammation in the body. And two, because it's actually a pretty neglected area in spinal cord injury research. So we ran an RCT where we took individuals with spinal cord injury and we randomized them into either a 12-week anti-inflammatory diet or a non-dieting control condition. I will say for the anti-inflammatory diet, it's not one particular diet. It's not like the Mediterranean or the DASH diet. It's really just a focus on trying to increase whole foods, foods with high nutrient densities. And so foods with established anti-inflammatory nutrients, things like omega-3, antioxidants, promoters of gut health like fiber and probiotics. And then equally as important, trying to eliminate any of those ultra-processed foods that have low nutrient densities. Things like refined carbohydrates, your refined sugars, your white breads, your white pastas, unhealthy fats, also fats that have foods that have an unfavorable omega-6 to omega-3 ratio, and also foods with high sodium content. Also, what was really important to this study was that we provided a number of behavioral supports. So everybody got a diet consultation to start. We had weekly phone calls, three times per week. We actually provided an online support group where people could discuss the diet and the struggles that they were having, share recipes, a number of resources, food logs, budgeting tips. So people were very well supported while they were on the study. And then, so outcomes, we took a look at baseline 4 weeks and 12 weeks, serum biomarkers, so we could take a look at inflammation and some of those kynurenines, as well as the impact that it had on neuropathic pain, depression, and safety and adherence. And so what we found is we did have very strong compliance to this diet. So by 1 month when we assessed, we had over 87% compliance to the diet, and that was maintained to the 3-month mark of the diet. And along with that, we saw a number of significant group by time interactions. So one was in inflammation. So we did see a significant reduction in pro-inflammatory cytokines in our treatment group, which is what we were hoping to see. We also saw a significant reduction in that pain-inducing prostaglandin PGE2, and also importantly, a significant increase in tryptophan availability. So again, tryptophan being that important precursor for serotonin synthesis in the brain. And this translated into some pretty large clinical improvements as well. So we did see significant group by time interaction and significant reduction in neuropathic pain in our treatment group, as well as significant improvement in depression in our treatment group. And so, having these clinically meaningful results just from changing people's diets, we had whole foods and we had some supplements. That was the only change that we made. We were pretty excited that we were able to have some clinically meaningful results. And based on participant feedback and the strong compliance that we had, we thought this would be a pretty feasible intervention moving forward to help people control depression and chronic pain in their lives. However, we followed up 1 year after the study ended, and we disappointingly found a huge drop in compliance. So not quite back to baseline, but a pretty substantial drop down to about 43% 1 year post. And along with that, we saw depression shoot right back up to baseline. Neuropathic pain was trending upwards, but actually did remain significantly reduced from baseline, which I suppose was a nice finding. A little bit harder to explain, but it seemed that those improvements were a little bit more robust, which was nice to see. But really what we took from this 1 year follow-up was there's a problem with the feasibility of this diet. People aren't able to do it long-term. And so we followed up, we did some interviews, and we looked into some of the facilitators and barriers to participating in a diet like this. And so some of the major facilitators we found were family support. So while people were on the diet, they typically had their spouses and their kids doing the diet with them and supporting them on that. Health benefits achieved were a big facilitator. So we didn't assess until 1 month, but I can say anecdotally, after about 2 weeks, people started reporting that they were feeling better, their mood was improved, their pain was reduced. And once we hit that point, it was a lot easier for people to justify sticking to the diet. Also autonomy over meal choices. So we didn't tell people exactly what to eat for breakfast, lunch, and dinner. We told them which foods to eat and which foods to avoid, and they had some autonomy over how they set up their meal plan. But there were some major barriers and some barriers that we weren't able to overcome. I would say number one that was reported by everyone was cost. So they found that eating healthy was too expensive, and this was particularly the case for some of the supplements that we had people on. Also, a big one was just the burdensome nature. So, we were requiring people to plan ahead, to change their shopping habits, to change their cooking habits, and it was burdensome for people. And that was particularly the case because of the loss of family support. So while family support was a facilitator, after the study ended, People reported that their spouses, their kids were no longer interested in following the diet, and participants were understandably not willing to do 2 separate grocery shops, cook 2 separate meals that they could carry on with the diet while their family didn't. So this is what brought us to this potential use of intermittent fasting as an anti-inflammatory treatment. Because intermittent fasting, it does eliminate many of these barriers. Costs are eliminated, and it's really actually a cost-saving strategy because you don't have to purchase as much food. There's also no meal planning, so they don't have that burden associated with it. And then family support, well, it's always important, but it's less of a factor with intermittent fasting. And so there is a growing body of literature suggesting that intermittent fasting can benefit inflammation. And so this is suggested to be through a number of mechanisms, one of which is the impact that it has on adipose tissue. So both structurally and functionally, it can help to reduce adipose tissue, as well as alter its endocrine function and the release of adipokines. Also improved insulin sensitivity. And so with improved insulin sensitivity, avoiding some of those blood sugar spikes that come along with inflammation, as well as improved gut health. So there's been some studies suggesting that intermittent fasting can have a positive effect on the microbiome, and along with that, the production of short-chain fatty acids and altogether helping inflammation as well. I will say that the major caveat to intermittent fasting as an anti-inflammatory right now in the literature is that many of the studies have been done using small sample sizes, and a large number of them are not RCTs. And one of the main reasons for this is that a lot of the studies have been done on people doing religious fasting during Ramadan. And I think, I mean, it's a convenient sample because you have individuals who are doing a fast anyways, so you can assess them pre-post, and it's pretty convenient. But with that, they're not randomized, and very frequently these studies are run without control groups. And then on top of that, there's a lot of heterogeneity in the participants used in these studies, as well as a lot of heterogeneity in the fasting parameters. So there's various ways that you can do intermittent fasting, and oftentimes calorie restriction is also grouped in along with these intermittent fasting measures. So it can be a little bit hard to parse out exactly what the effects of various intermittent fasting methods are. So we're going to be running an intermittent fasting randomized control trial. It'll be starting this summer into the fall. One of the first things that we've done over the past year is we've developed a smartphone app. And so this is in hopes that we'll be able to provide people with behavioral supports whenever they need it, and also something that people can carry forward with them after the study ends and continue to have those behavioral supports rather than cutting them off when the study ends. So in this app that we've developed, you'll be able to set and track your own fasting windows. You can receive fasting reminders, start and stop times. You'll be able to take notes and record any adverse events. We also have an explore page, so it's full of educational content, so study information in layman's terms. Participants can also set goals and then track their progress, so both their weekly and their monthly progress they'll be able to see. And so what we'll be doing for the studies, we'll be taking, again, a group of individuals with spinal cord injury, and we'll be randomizing them into either the intermittent fasting plus behavioral support group or a non-fasting control group for 8 weeks. And then we'll be looking at safety and adherence, as well as depression and anxiety, chronic pain, and again, some serum biomarkers to see if it is having an impact on inflammation, and some kynurenes from the kynurenine pathway. So really future directions for this study, the hope is that we will see intermittent fasting has some benefit on inflammation or some benefit to the kynurenine pathway, and possibly some benefit to depression and chronic pain as well. I don't expect that intermittent fasting will have the same magnitude of effect as a whole diet intervention like we've done with the anti-inflammatory diet. But we're hopeful that it will have some partial benefit, that it may be possible to then in the future pair it with a toned down version of the anti-inflammatory diet. So possibly having an anti-inflammatory diet, that includes a cheat meal once a week to allow people to stick to it more long term, or more of a simplified anti-inflammatory diet. I didn't get into all the specifics, but participants were given a pretty long document with all of the foods that we wanted them to eat and avoid on this study. And we may see better adherence long term if we were able to simplify this down to maybe just some of the major players, some of the most pro-inflammatory and anti-inflammatory foods. And it may also be possible to tie intermittent fasting to a diet, really just using the supplements, some of like the omega-3s and the antioxidants that we had people on. Perhaps if we pair that with an intermittent fasting, we'll be able to have a more substantial anti-inflammatory benefit. So the plan is to run this study and to continue to develop this smartphone app. So we're going to incorporate more and more resources from the anti-inflammatory diet and more functionality to allow people to log and track their diet, which will hopefully make it less burdensome and easier to stick to long term. So overall, I think the take homes, depression and chronic pain share a common pathophysiological mechanism that is impacted by inflammation. And so it does make inflammation this accessible and suitable target for treatment. Diet can have a substantial impact on inflammation. And in our studies looking at spinal cord injury, we have shown that it can have a positive effect on depression and chronic pain. But I think also very important that we look to explore ways to reduce barriers to these lifestyle interventions like whole diet interventions so that it can be more feasible and more equitable for people to do long term. Thank you.
Terrific. Thanks for that, David. That's really exciting. I like to see the direction that work is taken. We do have some time for questions here. And as people are preparing their questions, I'm actually going to pitch one at you here. In listening to that, I'm coming at this from I'm involved in some work right now exploring things like fecal microbiota transplant for anorexia and other mental health disorders. And I'm just curious, you've interpreted the effects of the anti-inflammatory diet from obviously the perspective of the inflammation. Have you thought of, or would you be amenable to exploring something like the gut microbiome and the gut-brain axis?
Yeah, I would love to. That hasn't been an area that I've been in yet. I actually just attended a talk on Friday where this is actually what they were doing. They were looking at just supplementing with apple cider vinegar to try and increase acetate levels. And I think it was just a study of 11 individuals right now, so they're still early on. But they were showing some interesting changes simply from doing that to the gut microbiome related to depression.
Yeah, that's the work. That's the work I was
Absolutely.
talking about.
Oh, is it? Okay. Well, there you go. Yeah.
Yeah.
And so like,
Some of
yeah,
it.
trying to do that and incorporate some of the short chain fatty acids. Absolutely. I mean, I would love to get into that area. That would be something, yeah, certainly to look for a collaboration with somebody that has more of a background in the gut microbiome. But yeah, I would love to.
Yeah. Well, we should definitely try to connect afterwards. But I'm imagining that there might be sort of a combined effect happening here, that maybe some kind of change in the pro and anti-inflammatory cytokine balance in addition to microbiota variation or something could
Definitely, yeah.
explain even more of an effect. Yeah.
And it feeds in nicely with, I mean, some of the other work that we've got going on with the vagus nerve stimulation because
Right.
that gut
Yeah.
microbiome,
It's
the effect on
exactly. It's
vagal
all
So
it's all
yeah.
connected, my friend. Yeah. Nice one. Fibo, go ahead.
Hi, there's two of us here. It's actually Mulugeta's question.
Really interesting study and fascinating. And looking at some of the barriers around, grocery shopping expense and, support, long-term support. Are there any considerations for public health interventions and things like that in the future? And if so, what can be done?
Yeah, I mean, you may have more expertise in this as far as like the public health interventions go. That is, I mean, I will say because of the barriers that we identified, that was my original reason for the interest in intermittent fasting, because it was kind of an easy way to eliminate, the costs and the burdensome nature of doing the diet. I think it's also interesting that, we may not see exactly the same barriers if we did this in an able-bodied population, because it is also important to know we did it in spinal cord injury. So I think some of the barriers as far as getting out and doing those grocery shops can be a little bit higher for people with spinal cord injury as well. But yeah, I don't know. I think in terms of some other public health interventions, I don't know, that would be something I'm not personally involved in. So that would be something I think I would if you have some pointers, it'd be something I'd talk to you about.
But thank you. Yeah, it's very interesting.
Can I also ask a quick one?
Please.
Yep.
Thanks, David. It's super interesting. Did you track the weight of the participants as well?
We didn't. So this was one thing that was interesting. This was not a calorie restrictive diet. And in fact, we were asking people to eat far more than they typically do because we had breakfasts and morning snacks and lunches. So people actually had a hard time eating as much as we wanted them to. I can say anecdotally, we had substantial weight loss. I didn't include it in here. We had one participant was a young guy. And we had before and after pictures of him, and I mean, dramatic changes in his weight. So that is one thing that I definitely regret. At the time of doing this, we didn't have access to an accessible scale for like a wheelchair scale, so we didn't. But I know that it did have an impact on weight. So one of the big regrets from this is that we don't have that data, and I wish we did. But anecdotally, yes, it had an impact on weight.
Maybe you should share the diet with at least me.
I'm happy to share it with anybody who wants it. So just let me know.
I'm not sure I'm ready to give up my processed foods, but maybe I'll give it a shot anyway.
It's not an easy one to stick to.
Exactly, not in our culture. We did have a question. I just actually want to acknowledge I've got a visiting colleague here from the Netherlands, Dr. Bart Staal, behind me, who's listening as well. We were just talking. We couldn't remember the sample size of that first study, the anti-inflammatory diet study. David, what was that?
The first one was N of 20.
20. Okay, yeah. Sure. Thank you. Okay, super. Okay, thank you very much, David. Really interesting stuff, and really appreciate you presenting the work that you're doing there. And I should just also acknowledge this may be a good opportunity to mention the pain research crew there, the clinical research unit at Parkwood. I know you've got some connections with that, and just reminding people that we do have a strong pain research group happening out of the hospitals there that people could reach out. I'm sure if they needed to, you'd be a good link into that. Is that fair to say?
Yeah, absolutely. Yeah, absolutely. The PR crew, I mean, they're fantastic for helping out with ethics submissions and study design and anything you need. So yeah, certainly look to them if you need any help.
Thank you. Okay, super. And people who know me will know this is the world I love to live in, which is that sort of interstitium between different academic disciplines, because we're now going to shift tracks a little bit here. And Dr. Gail Teachman is going to bring in now more of a sort of critical social science perspective on pain, in addition to, I'm assuming, some exploration of alternative ways of understanding the pain of another person. Really excited to hear what Gail has to say, so I'm happy to turn over to you.
Thanks, Dave. Let me just get this into slideshow mode. Everything good on your end to see the slides okay?
Yep, that's perfect.
Great. So nice to meet everyone. I haven't yet been able to attend to many of the no pain sessions, so I'm really happy to meet some of the group. I think I've just been to one so far. Anyway, thanks for the invitation. And yes, I feel like we're sort of shifting gears here a little, which is kind of nice, shaking things up a bit with a different perspective in terms of the research that I'm going to share. I'm really just going to give a bit of an overview of a line of research that with my colleagues we've been developing, primarily looking at children and young people's perspectives on pain, their experiences of pain, with a real interest in the intersection of disability, impairment, and through the work we've come to take up this term, which we did not create, but the notion of everyday pain. So I'll talk a little bit more about how that has been defined to this point. I also wanted, before I get into it, to just acknowledge some of the key players that have been part of the team. So Dave actually was a co-invest. Well, we were supervising a master's student in the first study, which I'll share with you quickly. Dr. Fiona Webster, who is also at Western, has been part of this work. And key player is Dr. Katie Ma, who's here with us today in the talk. So I want just to start with this quote that really stood out for us in terms of the recent work that's published, well, fairly recent, 2021 in The Lancet, that's calling for a lot more attention to children's pain. So basically just child pain matters, but not, it seems, to everyone, and not for every child, and not for every pain. The pain community has to work harder to make child pain matter to all, understood and visible, and to make it important enough to bring out into the open and to be acted on. Only then can pain be made better. So, I mean, I think it sets up the work that we're interested in doing. In my program of research is primarily focused on children, childhood disability, rehabilitation, and an area of, you know, the ethics that underpin those areas. So again, not talking about ethics as in sort of procedural ethics, but what are the kinds of values and norms that underpin the ways that we proceed in children's rehabilitation. Some of the things that, you know, inspire or that led us to develop this line of research is thinking about the ways that living with pain really influences children's social connections and their overall well-being. There's very little work that really brings forward young people's perspectives in this area. And of course, you know, some of that has to do with still very common assumptions about what children can know and how they can share what they know, and how valued or like what weight is given to that kind of knowledge. Even though we know a bit about overall rates of pain or chronic and everyday pain, much less is known when it comes to within the sort of subgroup of children who are labeled disabled or who are living with impairment. And the last bullet here is really pointing out some of these things that actually we are quite concerned, and we've been looking at the evidence around the ways that especially impairment and disability are taken up in ways that are very conflated. They're used in as if these are the same, and I'm going to talk a little bit about how we might want to differentiate those. But also actually with this population, assumptions about pain going together with disability and impairment, and just a taken for granted assumption that these are happening at once and discussed in ways that really conflate them all. So our work is very much informed by a few different lenses, and I do want to bring those forward before talking about the research itself. So first, we bring lots of critical social science perspectives forward in our work, but in particular a critical disability studies lens. And relevant to this work would be the difference that's brought out here. So in contrast to biomedical perspectives, where disability is usually positioned primarily as a deficit, so something that is located within individuals. But a critical disability studies lens really draws on the embodied experiences and perspectives of disabled persons to argue that disability itself is produced through discriminatory and stigmatizing social relations. So critical disability studies relocates disability to the social level of production through stigma, negative values associated with difference, as opposed to in certainly the world where I have worked as a therapist for a very long time, disability is seen as a flaw, a deficit, very deficit-based approach to thinking about difference, where differences are assumed to be negative and to produce, less health, less satisfaction. It is primarily seen as tragic in that kind of a view. But why bother adopting a critical disability studies lens? In particular, bringing forward that perspective is one where there's a real commitment to unpacking some of these taken for granted ideas and concepts, like even things like how has chronic pain been conceptualized, how is it used, what is this new notion of everyday pain, how is impairment thought about in the same ways as disability, how is it different? And those kinds of things can help us really to reveal those social and political dimensions of disability, but also of pain, and how these things intersect with ideas that we have about children and childhood, as well as rehabilitation. So there's a lot there that, of course, I'm not going to unpack in this talk today, but just wanted to put out there that, like, when we think about what are the assumptions we have about children or about childhood, but also about rehabilitation. So it's not in any way suggesting that there is no value to rehabilitation, but it is pointing out to us that we might want to think about some of the ethics that underpin rehabilitation, which, for example, might have to do with a continual focus on return to normal, some sort of assumption that somehow being this idea of normal is the best way. It is the ideal way to be in the world. And so certain aspects of rehab really, whether intentional or not, reinforce this high value placed on normalcy in our culture, which again leads to, again, that is for sure one of the deeply ingrained values and beliefs that we take up. But also then, to really open up ways that we can then say, so like, how could this be different? Which might sound like, how is that a useful exercise? But in fact, it reminds us that we haven't always thought about certain concepts in the same ways we do now. Concepts and values and beliefs change, they change over time. We have all sorts of evidence of that. And we can actually think about how things can be otherwise. How could rehabilitation, as an example, be otherwise? How could we think differently about, trying to be more careful about how we use terms like disability, how we separate that from thinking about impairment, which again is also a contested term for lots of folks, but difference even. Why is it that certain differences in our societies are made to matter in particular ways, whereas other differences are accepted and valued? So I think this is just a favorite quote of mine that again has to do with this notion of, can disability itself be seen as something that allows us to think about how things can be otherwise? So these are some top disability studies scholars who suggest to us disability has an enduring potential to get us to think differently about the world. I'll return to this later in terms of how it helps in our work. For those not familiar with disability studies, I do just want to put out, like, you will hear me say terms, for example, like disabled child or disabled person, which is sort of a contrast to some of the ways that are felt to be appropriate in terms of person-first language. And that might be child with disability or young person with disability. So I would say people do have a particular stance. I am more aligned with critical disability studies in my thinking, but at the same time, there's not really a right way to talk about disability or think about disability. In my view, it's something that we bring forward in terms of, certainly in research, for example, asking young people how they think about these things. What's the sort of language that they prefer? How do they think about disability? Do they identify as disabled? And certainly that's quite humbling, especially for those of us that have been in rehab for a long time, to come to understand that many, I would say many, perhaps the majority of young people that I've been involved with in research would be labeled disabled, and they do not themselves take up that identity. And we're learning, in particular in this area of pain, how young people navigate these identities, especially in relation to pain. But also here's a very, very brief definition of how we're taking up the notion of everyday pain, but in particular for disabled youth, this would include care-related pain or pain induced through activities that are thought necessary to manage the effects of impairment. So an example there might be, and we'll return to this with one of the young people talked about, some young people might, for example, wear a certain kind of a brace, like a leg or a foot brace, that provides certain kinds of support for their standing or for walking, but that might also induce fairly significant pain, especially over the course of the day. That might be an example for some young people of this kind of conflation of impairment, with disability, with accepting that pain is just there, that it's just part of impairment, it's necessary, as opposed to questioning why are we not paying attention to this? Is it possible that these things would not need to cause pain? Are we paying attention to preventing some of these things? And in particular within rehab, it's something to think about in terms of how many different types of intervention may also very much be inducing pain, and yet we're in a society where we still hang on to values like no pain, no gain. And again, young people take up these ideas and internalize those ideas in order to then perhaps try to make sense of the ways that pain is a part of their life. Also just pointing out that, again, there is now much more trend, not just with children and youth, but with adults, to engage people with lived experience in research. And yet at the same time, often there's not a lot of weight given to the views that people bring forward. So here, just reminding that there is a lot of research demonstrating that even very, very young children are in fact able to share understandings of what they think is right and fair in their life and what their experiences are. Certainly most of the young people that I talk to through my research have a wealth of experience, given long-term immersion in rehabilitation sites or different types of treatments and interventions. And it's not the kind of experience that a parent can necessarily bring forward at all in the same way as that young person who is living that. But also the notion that, kind of tends to decrease the idea that children have agency, that they can have a sense about what's at stake and weigh in on their views. And again, we do have ample research to demonstrate that these are false assumptions that we need to continue to push back. So it is one of the things that is key in my research, and that one of the main commitments is to bringing forward the perspectives of young people, especially those that have been excluded most of the time from research. So that would include, say, young people who communicate in ways that are not primarily speech. They might be using augmentative and alternative communication. And again, this is really just a key quote making the argument, regardless of legal debates, lack of competence doesn't remove the right to express a view. And for children, this again is one of those thorny issues where being deemed incapable tends to have the effect that children are then just basically left out of conversations. Their views are not elicited. So here it's more, asking for a much more nuanced way of thinking about children weighing in on what matters to them by not leaving them out of conversations, and recognizing this doesn't mean that they have to be deemed legally capable or competent. Even, and you'll see with this one reference, we've certainly argued even in the situation of people that are deemed cognitively impaired or developmentally delayed and some of those kinds of terms. Again, ample evidence that these are still people who are able to weigh in on what matters to them and can help us really produce important knowledge. So what have we done? I'll get into now these small studies that are like gradually building studies. One of the first ones was, as I mentioned, together with Dave, supervising a master's student who brought her own lived experience of pain forward and wanted to do research with quite young children. She opted to develop an arts-based method that was based quite closely on Dr. Ma's research. So young people, they had an option of drawings or paintings. They produced something, and it was basically using art as an elicitation method. Here we're seeing one of several drawings that these young people produced. Here this young person's labeling their painting, "When My Pain Gets Worse." So yeah, I'm not going to go into all the much more detailed methods and also the results, but I just will highlight a few things that, for me at least, really bring forward how valuable and interesting some of the perspectives these even very young children in this study, because this happened right at the onset of the pandemic. So the student was able to only recruit 3 young people. So although she had really rich data, only with 3 young people, and they ranged 6, 9, and 13 were the ages. But here again, interesting ideas coming forward where this is a child who's, producing paintings, but talking about them later in the interview, trying to explain that even a lot of pain, like when pain is worse, it can somehow be better. It can be helpful. It helps you learn how to cope with it. And the next time, if you get something bigger, it'll be easier than the last time. So again, there's many ways to interpret some of the things that young people are talking about here. One of them, though, that's very interesting from a kind of a critical social science perspective is looking at how it is that young people are learning to make sense of living with pain. How are they taking up discourses in the world around them that tell them, how it is to understand pain, what pain means, how they should make sense of pain. And we can see this very active work being done in terms of trying to find the positives, trying to see the lesson, trying to learn from pain. There's also, though, incredible depth and nuance. And this particular quote in the blue box always makes me smile. If some of you are familiar with the work of Drew Leder, has several books very focused on pain and talks very much about the absent presence of pain. It's a very philosophical work. And yet here we see in this 6-year-old's quote, trying to explain to the researcher how pain never really departs. It's present even when it's absent. And the child says, like if you just touch a chair and you take your hand off of it, you can still kind of feel like it was just there. That's where the pain is supposed to be. So it doesn't necessarily hurt. You can just feel that the pain is there, but it doesn't necessarily hurt at the moment. So again, clearly this is qualitative work. And so there's always that element of, interpreting through these different lenses. But I think the richness here of how this young woman is basically bringing forward some of the same ideas that Drew Leder has brought forward, albeit, sure, framed in a much more complex way within philosophy. But the notion that the pain's really always there. And to me, she has quite a vivid and rich way of trying to explain that to the researcher that she's talking to. Again, this is quite a young child. So on the side here, I've also just included a quick screenshot. For this work, we have published primarily based on the methodology. Katie Ma, Dr. Ma led this work, but trying to again bring forward how these methods have been really incredibly powerful in terms of bringing forward young people's perspectives and eliciting the kinds of conversation that allow them to talk about the pain that they experience. So following on that study, and again, I'm just giving you snippets here, we then looked at thinking about trying to do more work with a slightly older age range, so kind of like middle school aged young people. And here we thought we'd use body mapping, but prior to doing that, we did a scoping review, which again was a student's master's work. Now the image on the left is actually a bit of a summary, because what we'd like to do next in this work is bring forward the summary of the scoping review to groups of knowledge users, in particular people that are clinicians, professionals in children's rehab, to see what they feel like, what's their response to this scoping review. So this is a bit of a summary for those folks, but here what I wanted to summarize is the scoping review findings really illustrated the ways that pain and disability and impairment are conflated in the literature, to the extent that everyday pain may be taken for granted as an inevitable consequence of living with impairment, and thus overlooked by clinician researchers and even disabled youth themselves. And again, this really was looking at scoping there is not a lot of it, but scoping what research there is that tried to elicit perspectives of young people who identify as disabled and are living with pain. And we're certainly seeing that, to me, the most distressing is the notion that all of this messaging suggests to young people that it is their lot in life to live with pain, because this goes together with impairment and disability. So really, I'm just, these are the big questions that come forward from some of that is, how can we think differently about these terms, or what work do we need to do, or why might it be important to try to bring forward the idea of differentiating these terms, and if we're bringing forward more of a critical disability studies or even just disability studies lens, relocating disability and pointing out the ways that disability is produced through social relations, as opposed to thinking about impairment or difference. So again, as I mentioned, we decided to work with a slightly older group in the next study and work with virtual body mapping, really just to again look at the kinds of ways that, again, following the pandemic, we could be doing a bit more research online as opposed to in person, but also ways that the arts-based methods themselves can help to elicit and bring forward perspectives and share a little bit more with us around how young people themselves navigate understandings of pain and disability. How are they being impacted by the broader ways, so that discourses, the dominant ideas that shape how it is that they come to understand disability and pain, and how through body maps they can narrate more of that story to us. This is not a body map from our study. This is one that we actually used to help orient participants to the study and show them what a body map might look like. We recruited, we are actually still very actively trying to recruit for this study. We've only had 2 participants so far, which is challenging, but I think we've seen that across the board in studies since the pandemic in relation to recruiting young people, disabled young people to studies. We developed a guide that we could share online and sent art materials to participants so that they could create their own body map. So this is just a couple of pages from that. And here, again, this would take, I could easily talk about these for quite a long time. Here are 2 snippets from the body maps that were produced by the young people in this work. One is a young girl about 6, that's the one on the right, and the other you can see is a young woman, she's a teen who, to me, feels like she's got art in her future career. Very, very talented young woman who spent quite a lot of time and a tremendous amount of thought putting together her body map. And so again, we won't go into the results, but I think the quick things that I want to just share is the young woman on the right, quite a young girl, really literally talked a lot about how this is all just something that you have to get used to, you have to accept, you must just go ahead with it. No questions of the different kinds of things that were causing her a lot of pain. And this was one young person who talked about wearing the braces at school and what was required to wear these foot braces and the kinds of pain that they induced, and yet no real questioning of, what's going on here, just this sense that I must accept these things. Again, there's quite a lot that could be said. And again, we're really just in sort of analysis in process along with recruiting young people. But this is a young woman who is essentially portraying herself, in her words, as a rag doll. And so she chose to bring her body map forward in this way because not only the details, which again, we'd have to spend more time to hear about her explanation of why she drew her body map in this way. But one of the key points she was trying to bring across is the ways that she felt in terms of intervention around her pain, as though she was simply a rag doll through those moments. Powerless, she drew it without hands for a reason related to that sense of feeling that her own agency was gone. The imagery around the lips is again speaks a way of her saying that she feels she can't speak out about these things. She really has to just accept them. And you can get a bit of a sense here of sort of pain and violence around these ribs that seem to be poking into her body. And she's trying to get across there the notion that people just really can't understand what it's like for her at all times, but she's trying to show it through her imagery. So again, this is a study very much still in progress we don't have full analysis even for these two young people, but I think it's just very, very fascinating to see how evocative the images are, but even more importantly, how bringing together the arts-based methods with interviews opens up all kinds of ways for young people to share their perspectives. But I do want to just note, these are not exclusive methods to children. These are equally powerful and wonderful elicitation methods that have been used with adults as well. So to sum up, I really just want to point out that for us and the commitments that we have, by adopting a critical disability studies lens, I think the work continues to really highlight tensions in how disability is understood across different fields and how those tensions contribute to very real material effects for disabled youth. In particular, this notion that if youth come to bring into their identity this acceptance that living with pain is just the way it is, it's just the way the world, that has obviously very real implications for them, but also for professionals in the field who, if they're not hearing about the pain, if young people are not bringing it up, then of course, they're not able to address it. If nothing else, one sure takeaway is asking about pain far more often for this population is probably quite important, as well as thinking about how some of the kinds of ways that rehab professionals intervene with disabled youth might really need to be opened up and examined in terms of whether or not there is enough attention paid to how some of that pain could be reduced. One example might be, and again, there are many, and some of you might have lots of examples to bring forward. But some young people go through quite regular Botox treatments where they'll have many, many Botox injections. And typically they talk about this as incredibly painful. And yet in the research I've done, this was not research around pain, young people literally said, but I just have to do it, it's good for me. So we do have to be careful. Again, there's a message there about how as professionals, when we're suggesting certain kinds of interventions, young people understand those as good for me. And they're not very likely to question. And so perhaps we need to be the ones that are questioning more often. I just want to we're really out of time. We're going to leave this then for time. I just want to quickly, if you ever want to ask me or Dr. Ma or Dave about the developing area of critical rehab studies, reach out to us, let us know. And I'm not sure that we'll be sharing our slides later, but if we do, I've tacked on to the end here our 2 recruitment posters for the studies that are ongoing. And thank you very much. We'll stop there.
That's terrific. Thank you. Thanks, Gail, and thanks to both of you for being here today. First of all, I just want to acknowledge, Gail, the consummate professional. It sounds as though like life couldn't throw much more distraction at you in the background. I heard barking dogs and tweeting birds, and I don't know, perhaps someone mowing the lawn, and you just continued unflustered. So good on you. I just also want to say it was really important for me to have actually both of you here today, and as many of you know, what we're trying to do with No Pain is really come up, develop otherwise ways of understanding the pain of another person. And what you've both shown us actually are sort of, I'm not going to say they're opposite ends of a continuum. Hopefully there's some connection there, but 2 very different ways of trying to understand the pain of another person. And so that's really exactly what we're trying to do. Huge thanks to you both. The recordings will be edited and posted up on our website, so we'll let you know when those are available. Thanks to everyone for joining us today. Enjoy the rest of your day.